Hello. Good evening, students. So welcome to most important questions in respiratory and ABC. So just a minute. Okay. Starting with the first question. It will be more of a revision, testing your knowledge on common topics. There is a patient with DVT. He presents to the emergency room. Always this is examiner's favorite. DVT, and he is presenting to the emergency room with respiratory complaints. Sudden onset of shortness of breath, hemoptysis, chest pain. So whenever you see this, one suspicion is pulmonary embolism. Now the question they have not asked regarding pulmonary embolism. Which of the following is least expected in massive pulmonary embolism? See here, pulmonary embolism is actually pulmonary vascular disorder. It is problem in the pulmonary artery, not problem in the lung parenchyma. This is the first point that you should be knowing. And because there is defective gaseous exchange, you can expect central cyanosis. And when there is hypoxemia, your heart tries to beat more. When there is hypotension also, your heart can try to beat more. And as a part of pulmonary embolism, we have commonly exudative pleural effusion. There can be damage to the lung. There can be lung ischemia that can produce few inflammatory cells which can involve the pleura, resulting in pleuritis and also pleural effusion. So it is exudative pleural effusion only. Then what is not possible here? Breath sounds are generally present because it is not pulmonary parenchymal disorder. If it was pneumothorax, breath sounds will be absent. So the learning point here is, in pulmonary embolism, breath sounds can be present. Now my question to you, what is the investigation of choice in this patient? If they ask you investigation of choice, your answer should be CT pulmonary angiography. CT pulmonary angiography. Okay, next question. Coming to the next question. Features of sarcoidosis can include all except. So what you can see in sarcoidosis? Sarcoidosis is actually characterized by bilateral hilar lymph node enlargement. There can be cranial nerve pulses. Now my question to you, most common cranial nerve involved in sarcoidosis. Come on students, answer. What is the most common cranial nerve involved in sarcoidosis? Yes, what is most common cranial nerve involved in sarcoidosis? So it is your seventh cranial nerve. It is your seventh cranial nerve. So even cranial neuropathies can be present. Then what is the most common organ involvement in sarcoidosis? Most common is pulmonary involvement, because your lung is the most common organ involved. The symptoms will be cough, dyspnea. Then what is the most important blood finding? So in CBC, what is the main finding? You see lymphopenia. Because whenever sarcoidosis happens, it happens in the lungs. Your body fight against sarcoidosis with lymphocytes. Majority of the lymphocytes from circulation will go into the lung. Where will lymphocytes be? Less blood. Where will be the excess? In the lung. And based on this, what is the most important pathognomic finding in bronchoalveolar lavage? You should know it is lymphocytosis. If you see in the blood, lymphocytes will be less. In the bronchoalveolar lavage, they will be excess. So there will be increased CD4 cells when compared to CD8. So this is a pathognomic finding. They are asking you all except the most common hematological abnormality is lymphopenia, not lymphocytosis. This was a previous year question also. Then a 26-year-old male presented with progressive dyspnea on exertion for 5 months. He is a stone crusher. Wherever in respiratory medicine you come across an occupation called a stone crusher, what is he exposed to? Silica. He had long-standing whitish sputum production but denied fever, chills, weight loss, night sweats. So why this history is very important? To rule out a common infection in our country happening with the silicosis, that is tuberculosis. Patient undergoes bronchoscopy, bronchoalveolar lavage. It is milky white bronchoalveolar lavage, and it is also PAS positive. What will be the diagnosis? When you see silica exposure, milky white bronchoalveolar lavage, PAS positive. So your direct answer should be pulmonary alveolar proteinosis. This is happening due to excess accumulation of surfactant. Excess accumulation of surfactant. Now, coming to the revision questions. What is the most common form? Most common form is primary form. And why does this primary form happens? It happens due to autoantibodies against a factor called as granulocyte macrophage colony stimulating factor. Now this factor is essential for proper macrophage formation, and your macrophages are the one removing surfactant. Then what is the treatment of choice? Treatment of choice is whole lung lavage. Whole lung lavage. Somebody is asking how silica is related. Silica particles can directly damage alveolar macrophage. So they are toxic to alveolar macrophage. Whenever somebody inhales huge amounts of silica in short duration, it can damage the alveolar macrophage. Surfactant is not cleared properly. Got it? So the answer here is pulmonary alveolar proteinosis, and these are the revision questions that you should be knowing. It happens due to excess surfactant. Most common is primary form. Treatment of choice is whole lung lavage. Then, what are the following statements true regarding bronchial obstruction except? Following statements are true regarding bronchial obstruction except. So bronchial obstruction generally is responsible for collapse. So collapse is a part of lung not having air. So this is volume loss. Volume loss. Then what is the PG aspirant? What is the history given? See here, to exclude TB. So TB will have fever, weight loss, night sweats. Okay, this is how I have excluded TB. TB is an infection. Okay, then because there is volume loss, it is a pulling lesion. This is a pulling lesion. So whenever there is less volume, to compensate that volume loss, the mediastinum will be pulled towards same side. So you can expect mediastinal displacement towards same side, because collapse means there is no air. No air in the sense there will be absent breath sounds. So breath sounds can be absent. Then bronchial obstruction can predispose to bronchiectasis. Now see here, consider this is your bronchus, there is an obstruction. If unfortunately distal to that obstruction there is some secretions, so anywhere static secretions will attract infection, that will cause inflammation, that can cause destruction, dilatation, and later resulting in bronchiectasis. This is the one of the common mechanism of bronchiectasis. There is an obstruction distal to that some secretions. That secretions, if they get infected, there will be inflammation that can result in bronchiectasis. What is this theory called as? Come on, answer students. What is this theory of obstruction, infection, inflammation, destruction, dilatation called as? This is called as vicious cycle theory of bronchiectasis. So this is also true statement. And if anything has to fall into the lung, aspiration, anything falling into the lung is aspiration. Aspiration more common on the right, because when compared to your left main bronchus, my right main bronchus is short, it is stout, it is a bit straight. Because of this, any object falling into the trachea, it has more chances to fall onto the right side. So the inhaled foreign bodies usually lodge in the left main bronchus is a false statement. Inhaled foreign bodies usually predisposed to right side. Right main bronchus, it is short, it is stout, and it is a bit straight. Then a known asthmatic coming to the emergency department with the silent chest, altered sensorium, and high PaCO2. What is the next step? What is this form of asthma called as? It is called as life-threatening asthma. This is life-threatening asthma. There is so much of bronchospasm. There is so much of bronchospasm. Oxygen is not coming into your body because oxygen is not reaching the brain. There can be altered sensorium. Then there will be decreasing respiratory effort. Previously, patient respiratory muscles were fighting against obstruction. They were taking about 30 or 40 per minute. After some time, your respiratory muscles will become fatigued and they'll stop working. So that will reduce respiratory effort. And because of extreme bronchospasm, now air will not flow into the bronchus. There will be absent breath sounds. Previously, when it started, there was bronchospasm. Still some place for air to go in, come out. But as time progresses, there is extreme bronchospasm. Nothing will go in, nothing will come out. And this is referred to as silent chest. At least there was some noisy, wheezy chest. Now nothing is audible. So it is called as silent chest. It is a worst sign. So after some time, this respiratory effort can stop. Result can be respiratory effort can stop. There can be respiratory arrest. Then, because nothing is going in, what will further decrease? PaO2, SpO2. Nothing is coming out. What will increase? PaCO2. PaCO2. So here already patient is in a very bad situation. Respiratory effort is going to stop. So here nebulization continuation will not be sufficient because you need to save the life of the patient. Patient in altered sensorium, he is going to die in next few minutes. What you should immediately do? You intubate and initiate mechanical ventilation. You intubate and initiate mechanical ventilation. So Kirti Abhilasha. So you are forgetting the whole concept. Type 2 brittle asthma, laryngeal edema. I am not speaking about laryngeal edema. So it is bronchospasm. Don't get confused. Really, if you see a type 2 brittle asthma, in the casualty, by the time he reaches you, he will not survive. Somebody is asking, Anshita Jain, if bronchi is constricted, how will you intubate? Anshita Jain, please know, endotracheal tube is not going into your bronchus. It is here in the trachea. Okay, trachea is not getting constricted. It is not tracheal asthma. It is bronchial asthma. Please have clarity, Dr. Anshita Jain. It is bronchial asthma. Here everything has closed, and here also there is spasm in the central airways, but still you can put a tube. There is no other way. Can you suggest any other way, Dr. Anshita Jain, to save this poor patient in the emergency department? So common sense is most important while answering a question in NEET PG. So it is not rocket science that you should be knowing. What is the best thing that you can do in the next point of time is what is asked in your exam. Got it? Don't make these mistakes. No need to be sorry, because if you make this mistake in the exam, you will feel sorry. Then a 65-year-old construction worker, again, construction worker presenting with, when they say any worker occupational lung disease is suspect, and construction worker, one possibility may be asbestos, may be silica, but they have shown lower lobe fibrosis, pleural opacity. When you see this situation, pleural opacity and lower lobe fibrosis is pathognomic of asbestosis. So Amit Patre, see, tracheostomy is a last resort. First you intubate. If patient is, why do you want to do a surgery? By chance, Amit Patre, if you become a surgeon, even for a small wound in the nail, will you completely excise that finger? Please, Amit Patre. So don't completely remove the finger because you are a surgeon. There is also something called as less aggressive management. You intubate, patient is not coming out from ventilator, use tracheostomy as a last resort there, Amit Patre. Got it? Okay. Asbestosis, this can happen in occupations. Shipbuilders. Then construction workers. Next, here most important is pleural plaques, and specifically fibrosis in asbestosis is lower zone fibrosis. Now the examiner's favorite question. Asbestosis has max malignant potential. Out of all the substances, max malignant potential. Many people have answered. It means you are revising very well. Most common malignancy is lung cancer, that is adenocarcinoma. But special for asbestosis, most specific malignancy is mesothelioma. Please don't forget regarding this. Whereas silicosis, the key words, upper zone nodules. If you notice in the question, upper zone nodules, progressive massive fibrosis, hilar lymph node enlargement. Now tell me, what is the type of calcification there in that lymph nodes? What is the type of the calcification? Eggshell calcification. And NSIP is not occupation related. Hypersensitivity is not due to mineral dust. It can be due to organic dust. Some plant and animal dust must be responsible. So this is a classical picture of asbestos related lung disease. So if it is silicosis, you expect upper zone nodules, progressive massive fibrosis, hilar lymph node enlargement with eggshell calcification. Then this is a straightforward question, but still I want everybody to have this image in your mind because it is commonly asked. There is a patient with hemoptysis, clubbing, copious, foul smelling sputum. Many conditions can be differentials. Then CT chest shows the following underlying condition. CT chest shows the following underlying condition. So actually this was given in one of the exam. It was based on a recall. Now you notice here there are dilated airways looking like parallel railway tracks. So this appearance is called as a tram track appearance. This is called as tram track appearance, because in NEET you will have such questions. So this is bronchiectasis. So definitely it is bronchiectasis. Now, is it cystic fibrosis, yes or no? This was a question as it is definitely not chronic bronchitis empyema, because here it is a classical bronchiectasis. If it was some other history was given, so this patient was having infertility, there were some abdominal symptoms, pancreatic insufficiency, then cystic fibrosis will be a better answer. Only lung symptoms, bronchiectasis, if is shown in the image, go for bronchiectasis. I still doubt in that exam, maybe they have given cystic lung disease, but most of the students have messaged me cystic fibrosis. They must have confused. But if at all such a question comes in your exam, if you look, if there are non-pulmonary manifestations also, such as infertility and also associated with abdominal symptoms, pancreatic insufficiency, since childhood there is history, then your answer should be cystic fibrosis. Then a 32-year-old HIV positive. Again, HIV positive is very favorite for NEET examiner, and they'll ask you the respiratory manifestations. And if you see HIV GGOs with dry cough in this sense, features of atypical pneumonia. So there can be atypical pneumonia. And they have mentioned CD4 count less than 200. What should be your diagnosis? What is this pneumonia? Pneumocystis pneumonia. So in pneumocystis pneumonia, what is the drug of choice? Your answer should be cotrimoxazole. Now somebody tell me, what does cotrimoxazole contain? It contains two drugs, trimethoprim plus sulfa methoxazole. And one more important thing, drug of choice is a cotrimoxazole. Prophylaxis against pneumocystis is also cotrimoxazole. Now, another question. In the diagnosis, what are the names of special strains? I want everybody to write at least one strain. So your first answer should be right Giemsa strain, GMS strain, that is Gomari, Methamine, silver strain, and also we have the recent immunofluorescent strain. These are the revision aspects. Never forget regarding right Giemsa strain, Gomari, Methamine, silver strain, and also the immunofluorescent strain. Then coming to a 50-year-old smoker with hemoptysis and weight loss. Bronchoscopy reveals a central mass obstructing the right main bronchus, and also there was a chest X-ray given. Blood investigations show anemia and hypercalcemia. What is the diagnosis? Now go through this and tell me what is the diagnosis. See, many a time, day in and day out, I see this X-ray, then patient will be elderly smoker. Considering his age and his smoking history with hemoptysis, I do a bronchoscopy, I see a mass. Now he is a smoker, there is cavity, and it is very nearer to the center. It is central in location. Because there is a mass, most probably it is malignancy. And anything positive in blood, hypercalcemia. So if you see this combination, I always tell to my students 3 C's or all C's. Cigarette smoker, cigarette, cavity, central location, hypercalcemia. It is squamous cell carcinoma. Can anybody tell me why in squamous cell carcinoma there will be hypercalcemia? It is a paraneoplastic syndrome. The tumor cells will produce excess parathormone related peptide. Excess parathormone related peptide. Now my question to you. In small cell lung cancer, what is the most important electrolyte abnormality? Again, for this also I give a simple mnemonic. Small means less. All the less. We have hyponatremia, hypokalemia and hypocalcemia. Small means less. Hypo means also less. So if you come across a hypo, it is a small cell lung cancer. If it is a hypercalcemia especially, it is squamous cell lung cancer. Next. A 30-year-old presented with features of acute pancreatitis. Few days later he developed dyspnea. His chest X-ray is shown. So in the question there is background of acute pancreatitis. Okay. Then within few days. So short history. So you can consider it as acute shortness of breath and chest X-ray. Top to bottom, side to side, in all quadrants there are infiltrates. Bilateral, diffuse, pulmonary infiltrates. And the question they are asking you is, this patient is also having respiratory failure. Probably he is having hypoxemia. I told you, if you see this triad, acute shortness of breath, then infiltrates bilaterally, and there is a hypoxemia. What is this famous combination called as? Anybody? What is this famous combination? Acute shortness of breath, hypoxemia and bilateral diffuse pulmonary infiltrates. It is ARDS. And how will pancreatitis cause ARDS? Whenever there is pancreatitis, the damaged pancreas, from there enzymes are released into circulation. Any blood from any part of the body ultimately reaches the lung. These enzymes, when they reach the lung, it can damage the lung and result in ARDS. ARDS is a classical type 1 respiratory failure. ARDS is a classical type 1 respiratory failure. Then, a patient has presented with chest pain, breathlessness after central line insertion with the hypotension. Trachea is shifted to opposite side. What is the best management? First tell me, what is your probable diagnosis? This is something I tell to my students in my class. Whenever you have acute shortness of breath, absent breath sounds, hypotension and hyperresonant note. This is suggestive of tension pneumothorax. Now you should get a valid doubt. Sir, why are you thinking it as tension pneumothorax? The reason is one of the dreaded complication after inserting a central line insertion. Even an amateur person, if he inserts central line, in his mind it should be registered. If some patient worsens after central line quickly, think of tension pneumothorax. Because especially when you are putting a subclavian line, you puncture beneath the clavicle blindly. You are not using any ultrasound guidance. Blindly if you do, to access subclavian, you have to puncture beneath clavicle. If you puncture beneath the clavicle, accidentally lung apex might be damaged. Whenever lung is damaged, air escapes into pleura, and it results in a dangerous complication called as pneumothorax. And this is happening very suddenly. So much of air has accumulated. It starts compressing the adjacent lung, compresses the mediastinal vessels, reducing the venous return, resulting in hypotension because it has pushed the mediastinum to opposite side. Trachea will be opposite. So if it is tension pneumothorax, next step or best step, always save the life of the patient. First is life. Put a needle so that the pressure will be relieved. Once the pressure is relieved, compression reduces, circulation improves. But that single needle cannot drain whole air. For better drainage, you have to put an ICD. This is a tension pneumothorax, immediate needle decompression. This is first thing that can save the life of this patient. Then a 65-year-old female presents with progressive dyspnea, non-productive cough. CT chest is shown. Not much information. Once again, in ionized, they will give you a lot of information. In NEET PG, minimum information, maximum expectation. Just like your girlfriend. So she will spend minimum on you, but she expects maximum returns from you. So NEET PG is just like your girlfriend or boyfriend, whatever it is. So I am gender neutral. Okay. So less information, they have given you some CT scan. Now they are asking you predominantly on CT scan. What do you have on CT scan? So on the CT scan, there is a honeycombing. So if it is honeycombing, you should think of UIP, IPF. See, most of the people think like this. When I say males more than females, they think 99.9% only males will get, 0.1 only female. It's not like that. When I say males more than females, 51% males, 49% is also right. So always don't go by only gender. Think of everything. So if you see this, elderly is there, honeycombing is there. Still, if you think in terms of NSIP, then it is up to you. So see, medicine is not just about sex. Medicine is not just about gender. It is about all other things put together. If it is only about gender, you no need to study MBBS or MD at all. Just male clinic, female clinic, there ends the matter. Got it? So that's why I tried to confuse here. Even though the gender is a female, the manifestations are suggestive of UIP, usual interstitial pneumonia. When you don't know the cause, it is IPF. In IPF, initial treatment is pirfenidone. Now tell me, what is best treatment? It is lung transplant. And here, revision question. Somebody is saying slip of tongue. I never do anything involuntarily. Okay. NSIP, this is middle age. Females more than males. And on the CT scan, you see more of ground glass opacities. Usually a mild disease, treatment will be steroid. So if it is NSIP, you need to see this combination: middle age, female more than male, ground glass opacities, good prognosis. Then next question. A 55-year-old female with heart failure, CHF, develops bilateral effusion. Okay, what's interesting here? They cause effusion. Which of the following confirms a transudate? So they're asking you the Lights criteria to call it as transudate. So when do you call it as transudate? Transudate means it is a accumulation of clear fluid due to differences in hydrostatic and oncotic pressure. So this fluid will not have excess protein. So the pleural effusion protein by serum protein will be less than 0.5. Pleural effusion LDH by serum LDH will be less than 0.6. LDH is a marker of tissue injury. So because the tissues are not damaged, you don't expect excess LDH. And the value of pleural fluid LDH will be less than upper normal of serum LDH. So all these are features of exudative effusion. So they are asking you what is transudative effusion. Your answer should be pleural protein by serum protein should be less than 0.5. Any one of the following. If it is more than 0.5, it is exudate. Now, what is most common cause of transudative pleural effusion? Most common cause of pleural effusion overall, it is heart failure. So heart failure is most common cause of pleural effusion overall, most common cause of transudative pleural effusion also. Then a 50-year-old male in the outpatient department is being evaluated. So even though all these questions I have discussed many times in the class and also subject wise test, before exam these things should be registered in your mind. You no need to create any wonders, my dear students. Just avoid blunders. Blunders in the sense getting a common question, previous year question wrong. So if you get a common previous year question wrong, that is a blunder. Wonder means a very new question. Just yesterday itself the drug was released, you mark it. You are wonderful. But my job is not making you to create wonders predominantly. My job is to avoid blunders. So one such question that you should not commit blunder is this. In OPD, daytime sleepiness, memory loss, high BMI. Blindly my answer will be OSA. Non-hypertension. Nothing new. This fellow will have hypertension. This fellow will have wife problems. Along with that, because he snores. Along with that, ABG is given. What is different in ABG? Yes, he is awake. He is in your OPD. But he is unable to breathe. There is hypoventilation. When there is OSA with hypercapnia, this is not a simple obstructive sleep apnea. This is called as obesity hypoventilation. Obesity hypoventilation. So it means that the patient is so much obese. His body's fat is not allowing him to breathe. A lot of weight on his chest, lot of weight on his abdomen. When he tries to breathe, the respiratory movement is not happening. When respiratory effort is not happening, who will not come inside during inspiration? Oxygen. Who will not go outside during expiration? Carbon dioxide. So carbon dioxide pulls up. This is not simple OSA. And in central sleep apnea, the problem is only when he sleeps. Here he is awake. So when he is awake, there is also hypoventilation. So it means this is not sleep apnea. This is a total hypoventilation syndrome. Then narcolepsy, there is nothing relation to breathing. In narcolepsy, it is excess sleeping. Patient will sleep involuntarily. There is no problem in breathing. See here. In obstructive sleep apnea, the problem is only when he sleeps. But in OHS, there is problem each and every time he breathes. More difficult condition. Then this is every year asked question. High anion gap metabolic acidosis. The following is not associated with increased anion gap metabolic acidosis. I told you in my class also, one principle for anion gap to increase is there should be addition of acid. If anion gap has to increase, there should be addition of acid. Now if you see the classical causes of high anion gap, it can be any of the acids. Keto acids, diabetic ketoacidosis alcoholic ketoacidosis, lactic acidosis. And when will all these acids form not go out from your body? Your kidneys are not working, renal failure. And let it be any alcohol, it will get converted into aldehyde to acid. Methanol will get converted into formic acid. Ethylene glycol is nothing but antifreeze. It can get converted into oxalic acid. This aldehyde can also get converted into acid. And salicylate intoxication will also get converted into acid. Then other causes of metabolic acidosis without acid addition will not be high anion gap. So here there is no acid addition. Pancreatic fistula, ureterosigmoidostomy, diarrhea, carbonic anhydrase inhibitor use, aldosterone deficiency, renal tubular acidosis. Now they have asked which of the following is not high anion gap. Definitely these three are high anion gap. COPD is not at all a metabolic acidosis at all. COPD is a classical respiratory acidosis, students. COPD, type 2 respiratory failure, it is actually a respiratory acidosis. Only principle that you should know, for anion gap to increase, there should be addition of especially a strong acid to the body. Then, this is again a routine question, but most of you should not make a mistake here. A 48-year-old chronic alcoholic presents with fatigue, intermittent fever, productive cough with foul smelling, purulent sputum and digital clubbing. Chest X-ray is shown. What is the best initial management? So what do you see here? There is a cavity, there is air, there is fluid. Such a thing on a chest X-ray is called as lung abscess. Now what might be the cause of lung abscess? This fellow is a chronic alcoholic. Whenever there is a chronic alcoholic, you suspect possibility of aspiration. There is aspiration history plus lung abscess. This is primary lung abscess by definition. Now tell me, revision question. What is the most common cause of primary lung abscess? Who are the organisms? Your answer should be oral anaerobes. Next question. What is the treatment of choice for oral anaerobes? Your answer should be clindamycin. So there is aspiration history. How did I come to know there is aspiration? Chronic alcoholic. Then lung abscess. So this is chronic alcoholic with lung abscess. So it is primary lung abscess. The organisms are oral anaerobes. And the effective treatment will be clindamycin. This is not simple TB. This is not fungal infection because there is aspiration history, lung abscess. First preference will be primary lung abscess. And this is not malignancy to do immediate surgical resection. So when there is a medical condition, first treat medically. Only if it is not improving, then you can think of surgery. See, clubbing is a non-specific feature happening in so many respiratory diseases. Nobody knows the exact mechanism, but there is a theory that some chronic diseases will result in growth factors getting deposited at the tip of your fingers and toes. And these growth factors, the function is proliferation of the tissue. So your fingers become bulbous enlargement. So the reason is not known. Why clubbing? By clubbing you cannot diagnose anything. Clubbing is seen in respiratory diseases, cardiac diseases, GIT diseases, endocrine diseases. It is a non-specific sign. Historically, examiners were asking questions, so it has become famous. It is famous. Don't think everybody famous on Instagram are actually special. So even chaiwala has become famous in Instagram. You cannot get inspiration and become a chaiwala in future. So this just like in that way, digital clubbing is famous for you to identify that finding in exam, and for the examiner to ask this question, what is the theory of clubbing, what are the causes. But as a clinician, clubbing will not change my treatment decision. Got it? Hypertrophic pulmonary osteoarthropathy is commonly seen in which lung cancer? And clubbing, the advanced stage, it is called as hypertrophic osteoarthropathy, and this was frequently seen with lung cancer. Now clubbing means it is only limited to your fingers. Now that growth factors will cause deposition on your bones, and there can be joint pains also. There can be mild periosteal reaction and joint pains. So this was called as hypertrophic osteoarthropathy. And in which lung cancer clubbing is most commonly seen? It is adenocarcinoma. So if they ask you lung cancer with clubbing, now tell me, what are the other paraneoplastic syndromes with adenocarcinoma? It can cause hematological paraneoplastic syndrome. Can you name that hematological paraneoplastic syndrome? It is called as Troche syndrome. In the exam, if they ask you regarding Troche syndrome, think of adenocarcinoma first. Then there is a 67-year-old man presents with 2-year history of gradually increasing shortness of breath on exertion. Chest X-ray is showing large right pleural effusion. So whenever there is large pleural effusion, obviously you have to aspirate and you have to do analysis. Now there is milky fluid. First clue, examiner is very kind. Milky fluid. Now tell me, when there is milky fluid, what are the cause of milky fluid pleural effusion? We have one, that is chylothorax. Other is pseudochylothorax. Now if it is chylothorax, what is the pathognomic finding? Who will increase? Pleural effusion triglycerides will be more than 110 mg%. Other is pseudochylothorax. Who will increase? Pleural effusion cholesterol will be more than 200 mg%. Now I only have given you clue. Go through the pleural fluid analysis and tell me what is your answer. Protein LDH elevated, obviously it is exudate. Glucose, okay. Triglyceride, not much elevated. Cholesterol is significantly elevated. So this is a classical case of pseudochylothorax. And injury to thoracic duct actually will cause chylothorax, because thoracic duct is the one which contains chyle. If they ask you any question regarding pleural fluid analysis, this is the algorithm I want everybody to know. By seeing Light's criteria, please try to know, are you dealing with transudate or exudate? If it is transudate, life is very easy, because systemic causes, heart disease, kidney disease, liver disease, 90% this will be the situation. Story over. But if it is exudate, life becomes very difficult, because it will be similar as if you are dealing with your ex. You have to explain so many things. What all you have to explain? You have to do cytology to explain whether it is malignancy. Is it infective gram stain? Is it a TB? For TB we have special markers. It is lymphocyte rich, high ADA and high interferon gamma. Is it low glucose pleural effusion? As in empyema, malignancy, rheumatoid arthritis. High amylase pleural effusion. Pancreatitis, esophageal rupture, malignancy. Because of the lipid content, here the fluid will be white. Chylothorax, I told you, it is triglycerides due to surgical trauma. Pseudochylothorax, it is due to excess cholesterol. Here it is having excess cholesterol due to chronic untreated effusions such as TB, rheumatoid arthritis, or the usual things that can be caused. Next, ABG, and again keep this in mind, NEET examiner always tests your basic level of ABG interpretation. Mark my words, and you will remember my voice tomorrow while giving an ABG question. Mostly it will be basic level only. Write down the parameters. pH 7.20, bicarbonate 6, and CO2 13. Whenever they give you any ABG, draw arrow marks. pH reduced, bicarbonate reduced, and CO2 reduced. Whenever pH is reduced, first step always in ABG, see the pH. It is acidosis. Second step, what is the primary disorder? See the direction in change. Change in pH with respect to parameters, it is in same. So what should be the name? Metabolic. So this is a simple principle. If it is in same direction, it is metabolic. If change in pH with respect to parameters is an opposite, it is respiratory. I always tell this mnemonic, Rome. Respiratory opposite, metabolic same. Third is calculation of compensation. Whenever you get a primary metabolic disorder, you should calculate respiratory compensation. For metabolic acidosis, there is a special formula. Expected CO2 is equal to 1.5 into bicarbonate. How much is bicarbonate? 6 plus 8 plus or minus 2. Somebody good in mathematics, tell me how much is this value. Okay, how much is this value? So here it is 9, 17 and 15 plus or minus it is coming. So it is 1.5 into 9, 17 plus or minus 2. So this will be 15 to 19. So interestingly, here the CO2 level is 13. CO2 level is 13. So it means there is extra washout. So, body will only bring by CO2 to 15 to 19. It is less. So it is additional respiratory alkalosis. Then fourth step, calculate anion gap. So how much should be the anion gap? Is equal to sodium 136 minus how much is, what is the formula for anion gap? It is sodium minus chloride plus bicarbonate. Anion gap is equal to sodium minus chloride plus bicarbonate. How much is chloride? 110. How much is bicarbonate? 6. So 136 minus 116. So it is 20. So anion gap normal value is 8 to 12. Here it is 20. So it is high final impression. So final impression is high anion gap metabolic acidosis with additional respiratory alkalosis. So the best available answer is primary disorder is metabolic acidosis. Always primary disorder should be marked. So if they ask you, sir, why can't it be respiratory alkalosis? Here the primary disorder is not respiratory alkalosis, and here the primary, even though it is a mixed disorder, what must have started first? the metabolic acidosis must have started. So it DKA patient like this only they present. They'll have high anion gap metabolic acidosis. Because of that Kussmaul's breathing, some people overdo it. Because of that, there will be additional respiratory alkalosis. So here, out of all the options, best answer is high anion gap metabolic acidosis. So last question. A 23-year-old male with asthma has an increased respiratory exacerbations over the last year. So poorly controlled asthma. It is poorly controlled asthma. CT chest is showing bronchiectasis. Then in addition to sputum cultures to look for bacterial and mycobacterial infections, which of the following tests would be indicated at this point of time? Whenever there is poorly controlled asthma with bronchiectasis, one possible suspicion that you should have apart from other infections is ABPA, allergic bronchopulmonary aspergillosis. So at this point of time, reasonable test is serum IgE. See here, patient is not in emergency department, no need ABG. Bronchoscopy and bronchoalveolar lavage, already patient is able to give sputum for so that is sufficient for culture mostly, so not required. And you are not suspecting any pulmonary embolism. Here you are suspecting ABPA, first to go for serum IgE. So these are the features of allergic bronchopulmonary aspergillosis. This is actually a hypersensitivity reaction, but it is a complex hypersensitivity. Type 1, 3+4. Most important predisposing condition is asthma. And it is due to a fungus called as Aspergillus fumigatus. There will be skin test positive and IgE levels will be significantly high. According to new guidelines, it is more than 500, old guidelines more than 1000. Because this is an immune phenomena, antibodies will be there against this fungus. Presence of Aspergillus specific IgE and IgG. And importantly, on the CT chest, there is a classical finding called as central or proximal bronchiectasis. Blood can show excess eosinophils. This is more of a hypersensitivity reaction. So the treatment of choice is steroid. Whenever there is a patient with asthma, poorly controlled, and there is bronchiectasis, you have to rule out ABPA. So with this, we are done with most important questions. I tried to pick up from each and every topic so that you will not miss. So like I tell everybody, always trust your preparation. Last few days, no new things, no new relationships. Always fix to one source. Okay, whatever you are having till date, only follow that. Stay calm and focused. There will be so many attractions. Don't get distracted at this point of time. After exam, if you want, you can open your Telegram channel. Right now, please don't open any Telegram channel. Only open your app and do the questions. Believe in your instincts. Remember, you are always ready. All the best for NEET PG. Thank you, students. It was very great always interacting with you. Take care and all the very best. So why in fourth question? Okay. Bronchial obstruction. Why can't it be emphysema? See, everything is looking like it has completely obstructed. So it has obstructed. So it means there is no ball valve mechanism. So there is complete closure. All the options are suggestive of that. So even if you want to think differently, please think differently after completion of your post-graduation. So now if you think differently, because options are saying it is collapse. Collapse has happened. So breath sounds are absent. Mediastinal displacement has absent. So that's why you have to go with those options. So you are thinking about a rare possibility, which is rare things happens very rarely. There is an obstruction causing, especially in adults, a ball valve mechanism 1 in 100. You worry about 99 cases. 99 cases bronchial obstruction will present like this only. Okay. So ABG compensation, there are specific formulas for metabolic acidosis, alkalosis, respiratory acidosis, alkalosis. If given and expected are correlating, it is adequate compensation. When they are not correlating, according to New Harrison, it is called as mixed acid-base disorder. So if pH is 7.35 to 7.45, how to approach? You see the other values. So which is increased, which is decreased, and see any possibility of raised anion gap. If anion gap is high, then you should think of metabolic acidosis and proceed. So question number 20. What do you want in question number 20? This is ABPA because poorly controlled asthma and there is bronchiectasis. Next thing that you have to evaluate is allergic bronchopulmonary aspergillosis. This is the type 1, type 3, type 4. Because of type 1 hypersensitivity, IgE will be very high. Got it? Okay. Bronchiectasis. Asthma, this is not a fungal infection. This is a fungal hypersensitivity. Hypersensitivity. So how do you know hypersensitivity? Retrospectively, ABPA will cause bronchiectasis. So when there is a poorly controlled asthma and bronchiectasis, think of allergic bronchopulmonary aspergillosis. Inadequate compensation, no. Your body can bring it to near normal. So usually it will, very rarely it is normalized. pH will be near normal in adequate compensation. That is a statement given in Harrison. Okay. Thank you students and good night. All the very best.